So I'm not neurocritical care, sorry. I'm a neurosurgeon. That means maybe I'm the other team. I'd like to think not. I'd like to think we're the same team, and I've watched your area grow over the last decade in an amazing way, and you really are our partners. You're where the field is going, and you're where I've been for 30, 40 years, because I've been a physiologist. I've been interested in blood flow and how do you measure and what is the problem and what are the causations. So a disclosure, goal of the talk, need you to understand why quantitative blood flow is really the target. I need to give you some insight into new approaches to monitoring, and I need to give you an understanding of why the real goal is the continuous integration of all this data. So I'm going to step on some of the other talks a little bit because we're all talking about multimodal monitoring. We're talking about integrating multiple variables. And as a tribute to you guys, although I've spent all this time developing technologies, please, I've never forgotten, and you can't ever forget, that none of these are a substitute for you, the clinician at the bedside who's really looking at the patient, integrating all this stuff and making clinical sense out of it. So multimodal, what's multimodal? Multimodal means I'm trying to figure out if this is an elephant, and if you're only looking at the tail or the tusk or a big foot, you don't understand the elephant. And so any one of our tools just looks at a piece of the puzzle. And so our goal has to be to cross-integrate all this data in some physiological sense so that it tells you what you need to know about this patient. And I'll come back to that theme over and over. So just a little bit of philosophy. Some of us look at, early in our careers, we tend to be what I would call a lumper. You just want a simple answer. Hey, doc, just give me a simple answer. I want to fit all these patients into what category? Subarachnoid hemorrhage, that's the same. Trauma, all the same. Well, the answer is wrong. And the answer is the more senior you get and the more patients you care for, you realize that each and every patient is an individual with a very individual injury. And the next kind of an assumption, next kind of statement I want to make is, I'm being the philosopher here, gosh, you just don't want to make assumptions. You don't want to make your assumption. The one I like the most is, I do this because that's what my old professor taught me. Well, guys, now that I'm an old professor, I'll tell you, I don't know a whole lot, and I don't know what our old professors taught us. But we got to start all over. We got to build our information based on real data, and real data means measuring stuff and making real observations. We've already had an introduction to this kind of physiological overview, and what this really is trying to tell all of us, I think, is the stuff on the right. You want to know what part of the brain is at risk, not just what's dying, but you want to know what's at risk. And you want to know if there's something I can do to get the patient out of that risk. Are they in that penumbra, the oligemic thing? Where are they exactly? Now, ideally, we all have a PET scanner in our ICU, right? Everybody with a PET scanner in their ICU, just raise your hand, and you just roll your patients in and out of there 4 or 5 times a day, and it answers all your questions. Tomographic, physiological data of all the critical variables that you probably would like to have. And the answer is none of us have it. So what's reality? You do want tomographic data. Now let me carry you a little bit in my past because I've dealt with tomographic physiological data that we were acquiring with a CT scanner, and a portable CT scanner now, and inhaling stable xenon. By the way, it's better than it ever was, simpler and safer and cheaper. However, the FDA doesn't allow us to use it at the moment. But it gave us some premises. It gave us some insights that I think are important. And hopefully you'll get to use the technology later in your career. But in the meantime, the insights are important. Technology goes to the room. You get quantitative data. You get real numbers that are physiologically real. And most importantly, they are real because you can see the core, the penumbra, you can see the oligemic region, you can see the territory at risk, you can mess with the blood pressure and raise and then repeat a study and see what you're really doing. Quantitative, tomographic, real blood flow, repeatable. And I should mention we've done careful studies in primate cross-correlating CT perfusion with xenon CT, and the answer is CT perfusion is not quantitative blood flow. There's no value with CT perfusion that doesn't have an error bar so enormous around that value that it's clinically useless. So you can get transit time, you can get blood volume, but quantitative blood flow on a realistic scale that you can use clinically is not available with CT perfusion. So let me just share some concepts that we'll integrate into our thinking here. So we asked the question a moment ago about raising the blood pressure. Should we raise the blood pressure? How would you know if you could raise the blood pressure? Here's a patient with trauma, intracerebral hemorrhage, increasing ICP, CPP is being compromised. You're raising the blood pressure with dopamine. I'm getting some cardiac arrhythmias. What are we doing? Are we doing the right thing? Should we raise the blood pressure higher? What do we need to know? Well, if you had quantitative information, be it a probe on the skin or hopefully if you get an image like this, it has 24,000 blood flow values on a cut, you can see the blood flow doesn't look all that bad. These are values of about 40 throughout the whole hemisphere except where the contusion is, where it's clearly 5 or so. It's not. But that's the hematoma. Okay, what's the question? Do I need to keep the blood pressure at this height? Am I doing something good? And then if you repeated the study in a few minutes, amazing, because your assumptions, we all make assumptions, and as I said earlier, they're only too often wrong. So the assumption is that the blood pressure was raising the blood flow, making things better, and reality was we stopped the dopamine. The blood flow, in fact, came up a little bit. It didn't fall anywhere. What you were doing was not therapeutic by electively raising blood pressure to guide by CPP. What is our goal? What are we trying to accomplish? Is CPP our goal? Another kind of concept to test our premises we work with. Child, head trauma, lateral cortical area, severely contused, very hyperemic. ICP is 26. CO2, we're hyperventilating, 30. We doing the right thing? Are we helping the patient? Is that right? We've got the ICP down by running the CO2 lower. Well, what is the right thing to do? What if you raise the CO2, raise the ICP, but the CBF in the part of the hemisphere that is really alive that you're trying to save, you just took it from being ischemic that you were causing and you brought it back into normal perfusion. So in the upper slide, we get flows of 8 cc's per 100 grams per minute with hyperventilation where you were treating the ICP, but you weren't helping the brain. So a lot of questions. What are we doing? Why are we doing it? Do we know what we're doing? Do we need blood flow data? We desperately need quantitative blood flow data that's clinically useful. So I'm going to talk a little bit about things we do have. We have ICP. ICP is useful. It's been our standard for a long time. We know if we integrate it into our clinical protocols, the patients overall do better. We're not sure that exactly how that happens. It's the magic that all the things you guys do. But if you keep the ICP under some control, patients do better. However, lots of literature to say that ICP is not related. ICP high does not mean CBF low. Doesn't necessarily mean that. There's a lot of variations on that concept. So the optimum use of ICP would be to combine it. Combine it with arterial blood pressure. High ICP can be related, and is commonly related, the high CBF. I'll come back to that in a moment. So we talked about global measures. Now there's focal measures, all kinds of toys that we have that can give us focal information, some invasive, some non-invasive. Each has advantages, each has disadvantages. I think the first question is you start to put these probes on people, you start to look into a window into the brain or on the surface or a little hole in the skull, is what am I measuring? Where is it? What's it relationship to? So here I'm putting a probe in the right frontal lobe. Head trauma. Is that the right place to measure blood flow? How do I know? If you measure the blood flow at the same time, you just placed your probe into an area of severe ischemia. Is that what you really wanted to measure? Did you not want to be somewhere in what would be a penumbra? So we need some kind of physiological data to even guide where we put our probes. Where is the question? Where's the battle zone? What are we trying to save? So obviously the next day, what had no blood flow was a CT-defined infarction. But you need to make the decision the day before when the CT scan still looks normal. You need to know where the battle is. Sort of another concept. So if you knew where to put your probe, how many probes would you place? Do you want just ICP? You want just blood flow? You want just oxygen? And I can just share with you, I helped work with a technology that is this hummingbird deal, and it provides access with multiple ports to allow you to then do multiple things through one hole, because I don't have a lot of families that allow me to just keep drilling holes in people's heads because I've got another question. I got to do a lot with a little. So we put these probes and we put them in a very fixed manner. They go 2 centimeters down, they're 120 degrees apart, they're in the deep white matter, they're absolutely consistent in their placement. So now I can develop a reference base of hundreds of patients where I put probes exactly in the same relationship. Our initial work was looking at blood flow with the Hemodex and Lycox, oxygen, and ICP down the middle. And this has worked out to be an effective technology. We recently published a high efficiency and accuracy and safety using it. So how do we deliver things? What do we deliver? We've been delivering the Lycox technology, the Hemodex probe, the microdialysis in some patients. And by the way, on the bottom there, I say, I've quit looking at microdialysis after 5 years and a lot of money. It's not a stable technology in my hands, in our ICU's hands, looking at critically ill patients. And we've looked at the Cirox CBF probe. It combines NIRS and Doppler. It's sensitive to CBF changes. I'm still struggling with the exact depth sensitivity, and that technology is still evolving, and I'm told that the new technology is more sensitive in the depth of the brain than earlier technologies, but you certainly get information that correlates directly with oxygen changes, changes of ICP. Here's a patient I was doing a carotid upon, and as we clamped the carotid, you can see that both the brain blood flow and the somanetics oxygen dropped in an exact manner and came back up as the clamps were taken off. So it's a technology, provides evidence, it's non-invasive, it should be the goal in the future, and we're going to continue to work with it. But you know, with all those probes, we got too much independent information. How the heck do you deal with all these boxes and all these lights and all these things flashing? And in our ICU, there's just rows and rows of boxes flashing, and you can't keep track of it. It's just too much random information. So this technology has been instrumental in our hands. This is the Moberg device to integrate all the technology and put it and lock it in one computer. And we've done this now for half dozen years. We have a giant server. We capture every bit of information on every patient. So we can go back and not only look at that patient, but look at every patient we've ever studied. And so what comes out of it is really interesting, and here you can take 12 days of data, you can graph it out beautifully. Please note that the green is the oxygen probe. Oxygen looks pretty steady. The red is CBF. Whoa, the CBF is going away. This patient is dying. The MAP at the end there is going sky high. ICP goes sky high at the end. But note the oxygen remains stable through that entire course. So how do you deal with all this information? What's it trying to tell you? We were talking at lunch about, I'm looking at this data from one probe or another. I'm looking at one probe, only one, and you're trying to figure out what it means. I don't think you can figure it out from any one probe, be it blood flow or oxygen. You need it all. You need to find a way to integrate it. You need a way, here's another way of tracing, and this patient had a cardiac arrhythmia. We gave him adenosine, and guess what? The heart stopped. And you can see all the physiology that accompanied the heart stopping for a few moments. The CBF falls, the MAP falls, the ICP started rising afterwards. The heart came back. So you can track all this physiology. But I think the future is not in just having a bunch of squiggly lines going across and you're trying to figure out how exactly they all relate. And we were talking earlier about the privilege that I've had of working with a physicist who I snagged from University of Wisconsin. He's come down and he's my bright guy because he knows how to put this stuff together in a way that I've never been able to understand or figure out. So Marc Craftsbury joined us, and then we started talking about, how do we integrate variables? If we're looking at CBF and ICP, we were talking earlier about, does high ICP mean low CBF? So here we went and plotted 45 TBI patients, tens of thousands of bits of data. We look at the relationship of CBF and ICP. Now please note, that's age greater than 25 years, because we've got a few hundred of these folks. We're sort of looking at, is there a difference in age as far as the reactivity and changes of blood flow in relationship to ICP? And you see a pretty tight clustering of blood flow values with CBF below 40 and ICP below 20. If you look in the lower left, these are folks less than 25. And what I've been instructed with is how people less than 25, teenagers, even up to 30 years of age, do something uniquely different. They get high ICP and they get high blood flow. Commonly, not a rare event, at least a third of our patients have high ICP in that age group, have a hyperdynamic state. We just had a patient this past week, an aneurysm patient, a young person, and the ICPs were running in 40s and 50s, and oximeters are high, probes are high, everything is hyperemic. You're going to give him mannitol? His ICP is high. You're going to take the side of his head off? By the way, he's wide awake. What number do you want to believe? And so all we did was leave him alone and let him hyperventilate a little bit, and it all went away after a few days, and he's just fine. So what does ICP mean? Simple questions. I hear people tell me that measuring oxygen is a measure of blood flow. Well, I've got a rather unique situation. I've got a blood flow probe, I've got an oxygen probe, they're in the brain simultaneously on all these people. So I asked the question, what's the relationship of ICP, of blood flow and oxygen? And what's the relationship between the change of blood flow and the change of oxygen? And the answer is, it's just a giant cloud. There's no relationship, as we heard in the earlier talk. Oxygen, brain lycox, is measuring, it's very, very sensitive, but not terribly specific. And you can't use a change of oxygen in the brain and say, I'm measuring a change of blood flow. The data does not support that kind of a statement. So we come back to this stuff. Lots of data, 10 days of stuff, squiggly lines, too much for me to try to figure out. So here's the game. I have MAP and I have CBF. Are they related? Are those the same? Are they coupled? If you have a guy like Marc Craftsbury, a physicist, he does an analysis and looks and he tries to understand, can I superimpose this data? Can I shift the data one way or the other? Because each probe, an arterial line is in your arm, your blood flows in your brain, there's oxygen, there's blood delivery time, there's a lot of variables. So he shifts the curves automatically to see if he can line them up. And here in that patient with all those squiggly lines, you can see that you can line them up. And if you do that, then you can get a degree of fit, correlation coefficient. If it's a very high correlation, where CBF and arterial blood pressure totally superimposed, you have, by definition, a loss of autoregulation. You are directly, your blood pressure is totally driving your CBF. And you can do an analysis of the gain by delta positive or delta negative is an automatic continuous analysis of how those two variables are relating, and you can get the lower plot, which is a plot of the degree of autoregulation, the gain of autoregulation. You can get a measurement and plot the degree of autoregulation on a scale of 0 to 1. And here's where it really is going to become fun in the coming years, is because all of a sudden now you can see that when it's 1, you're not autoregulating at all. Your blood pressure is your intracranial pressure and your CBF. And so, but here's a patient that starts to autoregulate, and you see it comes down from 1 back to 0. So why did it do that? What did we do to make that happen? So that's the game. The game's going to be to better understand autoregulation. What does it mean? Well, how's it prognostic? How do we mess with it? How do we improve it? Because now we have access to it. Whether you use invasive technology or non-invasive technology, that isn't the question. Now it's a matter of cross-integrating as long as you have reliable variables. Last concept is how do you enhance, can you enhance the signal recognition part? And here's a fun game, which is going to be where I think where the game is going. We give nimodipine to patients all the time, and that gets a little blood pressure drop. Does that mean something? If you superimpose, you do a signal averaging of nimodipine after nimodipine after nimodipine, you do 30, 40 doses, all of a sudden, my God, you start seeing something coming out of that. You start seeing that you give the nimodipine, you have a absolutely reproducible, understandable drop of blood pressure. Well, that's not remarkable, but what is remarkable is you can also, in some patients, and not all patients, but some patients, you'll see an absolutely directly correlating drop of CBF. Now by definition, you're not autoregulating, your blood flow drops, and you've made your patient ischemic by giving them a drug which is designed to help the patient. There are some patients that are uniquely sensitive. Now the ultimate next game is the graph on the right, and that is if you have an oxygen probe next to your blood flow probe, and if your oxygen probe also drops exactly in the same time and the same degree, you have somebody who's extracting oxygen as the blood pressure drops just a little bit. And so you now have a PET scanner. You have a measure of CBF change and oxygen extraction from probes in the brain in your sick patient to a challenge. So I think the future is going to not be in the lots of more raw data, but it's going to be in how we're going to process it. I think we're making progress. The technologies are evolving and are getting better all the time. The cross-analysis, I think, is where the game is. And at the end of the day, it has to be this thing called KISS. We have to take all this complicated stuff and we got to make it simple. The nurse at the bedside doesn't want to see 14 different numbers. They just want to know, is it okay? Is it green? Am I concerned? Or is it red? We got to get it that simple. Thank you.